So last class, it was anatomy of ear, development and anatomy of ear. So going through the previous year questions, I saw a lot of MCQs from larynx. Surely it was from nose also. But larynx, there were so many repetitions in larynx. In the next 90 minutes, we will go through the development of larynx, anatomy of larynx, benign laryngeal lesions, and neurological affections of larynx. Okay. If you have need any other preferences, you can message me. If you want to cover any other areas, just message. Okay. So, development of larynx, anatomy, benign laryngeal lesions, and neurological affections of larynx. ഒരുപാട് MCQs repeated ആയിട്ട് ചോദിച്ചിട്ടുണ്ട്. Okay. So that is why I choose that areas. So coming to the development, fourth week of intrauterine life is again an important area, important time. So in the fourth week of intrauterine life, a laryngotracheal groove, you can see it here. Laryngotracheal groove develops in the ventral wall of pharynx. Okay, when the ventral wall of pharynx, there is a laryngotracheal groove, and this is lined with the endoderm. And endoderm of this laryngotracheal groove goes develop into the epithelium of airway. This is the future airway. Okay, so the cranial end of this laryngotracheal groove, or the upper part, the cranial head end of this tube, goes into larynx and trachea. You remember this this diagram. So the cranial end or the head end of this LT tube develops into larynx and trachea, and the caudal end, the lower part or the foot end, develop into two main bronchus. You can see it here. Okay. So any congenital, so the importance is that any congenital malformations of the pharynx and esophagus is always associated with the certain degrees of malformations of larynx and trachea. Okay. So remember that this pharynx and esophagus along with the larynx and trachea are common development. Okay. So that is why any congenital malformations of pharynx and esophagus is always associated with a certain degree of malformations of larynx and trachea. And this cranial end, from this figure you can see the cranial end of this LTG goes into the primitive larynx, and the epiglottis develop from the hypobranchial eminence. This is the epiglottis part, and this develop from the hypobranchial eminence, and laterally it is bounded by the ventral fold of sixth arch. So development is from fourth and sixth arch. So thyroid cartilage develop from the ventral end of fourth arch cartilage, arytenoid, corniculate, cricoid and tracheal cartilages develop from the sixth arch. This is usually asked as MCQ. Thyroid is from fourth, arytenoid, cricoid and tracheal cartilages from the sixth arch. And you remember the week 4, and also complete recanalization happens by around the 10 to 12 week. Okay, so week 4 and week 10 and 12, and this laryngotracheal groove, cranial end and the caudal end. And thyroid cartilage is from fourth arch cartilage, and arytenoid, corniculate, cricoid and tracheal cartilages are from the sixth arch. And the size of larynx is almost the same in girls and boys till puberty. Till puberty, you have to remember. And after that, the anteroposterior diameter of larynx doubles in male. AP diameter. If it is not doubling properly or the length is not increasing, then this female voice happens in males. Okay. So it actually doubles in male after puberty only. So that is a development. Remember this picture. The commonly asked one, what is the most important function of larynx? So our first concern will be phonation, but remember voice production is not the, it is one of the functions, but the most important function of larynx is protection of the lower airway. So that is why larynx is called the watchdog of lungs. Okay. So the most important function of larynx is protection of lower airway. There is other functions are respiration, voice production, fixation of chest, but most important one is protection of lower airway. Don't think that it is voice production. It is protection of the lower airways. Coming to the anatomy of larynx. In adult larynx, hyoid bone is at C3 and our larynx lies at the level from the level of C3 to C6. So from the hyoid bone up to the lower border of cricoid cartilage. So it is from C3 to C6. Okay. So the larynx lies opposite to C3 to C6 vertebra in adult. But the usually asked one is, what are the differences? Each difference can be asked as an MCQ. Difference between adult larynx and that of an infant. That is important. So in infant, larynx is usually higher up. I already told you the position is between C3 to C6 in adult, but in infant it is higher up. And epiglottis is leaf-like in adult, but in infant it is long, tubular and omega shaped. Okay. So leaf-like one in adult and long, tubular and omega shaped in infant. And again, the narrowest part you have to remember, the narrowest part of larynx in adult is glottis, but in infant it is subglottis, below the glottis, it is subglottis. Okay. And size I already told you, till puberty, the male and female size is almost the same. But after that, the size of male larynx doubles, especially the anteroposterior diameter of adult male is larger or double than of the female. But in children, there is no much difference. And Adam's apple is very prominent in adult males, but nothing like that in infant. And cartilages of infant larynx are softer and supple with abundant submucosa. So that what happens? It is more prone for laryngeal edema in infant and it is less prone in adult. Because the cartilages are softer and supple with an abundant submucosa, always the infant larynx is more prone for laryngeal edema. So that is why this acute epiglottitis, laryngotracheobronchitis and all other infections become more serious in case of infants. Okay. So these differences, each difference you should remember. And we can divide the adult larynx into 3 areas by 2 lines, 2 imaginary lines. The upper line passing through the apex of ventricle. What is this ventricle? Ventricle is an area between the false chord and the true vocal cords. So one line passing through apex of ventricle and another line 1 centimeter behind the first line. First line is passing through apex of ventricle and the second line is 1 centimeter below the first line. So by these 2 imaginary lines, the larynx is divided into supraglottis, glottis and subglottis. So supraglottis is an area above the first line. Glottis is the area between the 2 lines and subglottis is the area below the second line. And what all things are there in the supraglottis? From here you can see that one is epiglottis, another one is aryepiglottic fold, then arytenoid and the ventricular bands are there in the supraglottis. And the glottis is constituted by true vocal cords with an anterior commissure anteriorly and a posterior commissure posteriorly. And subglottis is an area below the glottis. So supraglottis, there is epiglottis, arytenoids, aryepiglottic folds and ventricular bands. That is a false chord. And the glottis by true vocal cords with anteriorly anterior commissure and posteriorly posterior commissure. And subglottis is an area below the level of vocal cords. Okay. So anatomical subdivisions are divided into supraglottis, glottis and subglottis by 2 imaginary line, one passing through apex of ventricle and another one 1 centimeter behind the first line. Okay. Then there are 6 cartilages The 3 are paired and 3 are unpaired. In this, the green border are the paired cartilages and the red are unpaired cartilages. Okay. So what are the paired one? Paired one are arytenoid. Arytenoid 2 in number, and above the arytenoid you have the corniculate and also cuneiform. They are paired. And unpaired, it's easy to remember from this picture. One is an epiglottis, which is a leaf-like structure. Then one thyroid cartilage and also one cricoid cartilage. And the cricoid cartilage is a signet ring shape, and it is the only cartilage to form a complete ring. ഒരു മോതിരത്തിന്റെ ഷേപ്പാണ് പറയുന്നത് സിഗ്നറ്റ് റിംഗ്. സോ അത് കംപ്ലീറ്റ് ആയിട്ട് 360 ഡിഗ്രി കവർ ചെയ്യുന്നുണ്ട്. സോ ക്രൈക്കോയിഡ് കാർട്ടിലേജ് ഇസ് ദ ഓൺലി കാർട്ടിലേജ് വിച്ച് ഫോംസ് എ കംപ്ലീറ്റ് റിംഗ്. ഓക്കെ. പിന്നെ ഇതിനകത്ത് ഇമ്പോർട്ടന്റ് ആയിട്ടുള്ളത് all the cartilages are elastic except arytenoid, thyroid and cricoid, which are hyaline. Okay. അതിന്റെ ഇമ്പോർട്ടൻസ് എന്താണ്? ഓൺലി ദ ഹയലിൻ കാർട്ടിലേജസ് കാൽസിഫൈ. സോ കാൽസിഫിക്കേഷൻ occurs earliest in thyroid cartilage. Remember that this thyroid cartilage, cricoid cartilage and part of arytenoid. Arytenoid മുഴുവനായിട്ടും hyaline അല്ല. Only some parts of arytenoid that I will tell you in the next slide. So the thyroid, cricoid and arytenoid are hyaline, and this hyaline cartilages calcify. This epiglottis is elastic. Elastic cartilage will not calcify, and you can imagine the if the epiglottis is calcifying, what will happen in old age? Or in old age, if it is getting calcified, the movement of epiglottis will not happen. So it will be a terrible condition, isn't it? So epiglottis is elastic cartilage, E for E. Remember like that. Epiglottis is elastic, so it will not calcify. But thyroid, cricoid and part of arytenoid will calcify because they are hyaline cartilage. And this calcification occurs earliest in thyroid cartilage that starts by 20 years of age. So in all of us, this calcification is started. In you people, also the calcification of thyroid cartilage is started. It starts by 20 years of age and it is fully ossified by 7th decade of life. And thyroid cartilage calcification is in a figure of 8 pattern. You see here, this in one part and again in other side. So it is a figure of 8 pattern. Calcification of thyroid cartilage is in a figure of 8 pattern. So in malignancies of larynx invading the thyroid cartilage, this figure of 8 pattern is destroyed. And hence it is very important radiologically. Figure of 8 pattern calcification of thyroid cartilage. Okay. And another thing you have to remember is this part. What is this? Thyroid cartilage, the angle of thyroid cartilage. It is formed by ala of thyroid cartilage. These two ala of thyroid cartilage will come and meet in the midline, forming an angle. And this angle is 90 degrees in male and 120 degrees in female. This is another repeatedly asked MCQ. Okay. So remember the paired and unpaired cartilages, and also they are elastic except thyroid, cricoid and part of arytenoid. And the thyroid cartilage is the first to start calcification in a figure of 8 pattern. Okay. It starts from by 20 years of age and it is fully ossified by 7th decade of life. And the angle formed is 90 degrees in male and 120 degrees in females. So I'm again repeating, which of the following laryngeal cartilage are hyaline? So see, these are hyaline: thyroid cartilage, cricoid cartilage, and the part of arytenoid, that is the basal part of arytenoid cartilage and process of arytenoid, vocal process of arytenoid. They are hyaline cartilage, and all others are elastic. They do not ossify. Epiglottis is elastic. Corniculate, otherwise called cartilage of Santorini, it is elastic. And cuneiform, otherwise called cartilage of Risberg, it is also elastic. So this slide you have to remember because usually asked exam. Next is membranes of larynx. Okay, membranes of larynx. There are extrinsic membrane and also there are intrinsic membrane. Extrinsic means exterior, that is outside the larynx. And intrinsic means inside the larynx. Extrinsic, there are mainly, this is hyoid bone, isn't it? So hyoid, thyroid, cricoid and trachea. So extrinsic membranes will bind all these structures. So one is thyrohyoid membrane. See, this is thyrohyoid membrane and it is pierced by internal laryngeal nerve and superior laryngeal artery vessels. Okay, so one is thyrohyoid, another one is cricothyroid, and the third is cricotracheal ligament. They are cricothyroid membrane. They are extrinsic membranes, and the intrinsic are two in number. What are they? Quadrangular membrane or the quadrangular membrane in the upper part and conus elasticus or cricovocal membrane in the lower part. They are intrinsic, inside the larynx. And the vocal ligament is formed by the upper border of the cricovocal or conus elasticus. Upper border of conus elasticus is a vocal ligament. And the lower border of the quadrangular membrane is the vestibular ligament. So, vocal ligament otherwise called the true vocal cord and vestibular ligament otherwise called the false vocal cord. So, quadrangular membrane in the thara bhagamana vestibular ligament or the false vocal cord, and the conus elasticus in the upper part is vocal ligament or the true vocal cord. Okay, so these are the extrinsic one and these two are the intrinsic ones. Okay. Then laryngeal muscles are also very important. So there are extrinsic laryngeal muscles and intrinsic laryngeal muscles. Extrinsic laryngeal muscles, I already told, like in extrinsic membrane, laryngeal muscle working outside the larynx and intrinsic one are working inside the larynx. So extrinsic are usually strap muscles, suprahyoid and infrahyoid, and also stylopharyngeus and palatopharyngeus. From larynx in as such item, the elevator and depressors, they are the extrinsic muscles. And the three muscles working on the lateral wall of thyroid, usually asked, they are the sternothyroid, thyrohyoid, and inferior constrictor. This you have to remember. This is repeatedly asked. So extrinsic muscles are actually suprahyoid and infrahyoid muscles, and stylopharyngeus and palatopharyngeus. And the three extrinsic muscles working on lateral wall, they are sternothyroid, thyrohyoid, and inferior constrictor. Next is intrinsic muscles. So the only interarytenoid muscle. Interarytenoid muscle means between two arytenoids. Again, it is divided into transverse arytenoid and oblique arytenoid. Interarytenoid in the two part ആണ് transverse arytenoid, oblique arytenoid. Okay. So only this interarytenoid muscle is unpaired. All others are paired. So the only intrinsic muscle which is unpaired is interarytenoid. All other intrinsic muscles are paired. Okay. And the next one is only intrinsic muscle lying outside the larynx is cricothyroid. Okay. And this cricothyroid is a tensor also. Okay. So only intrinsic muscle lying outside the larynx is cricothyroid. And the only abductor of vocal cord, it is otherwise called safety muscle of larynx. Which is that? Only abductor of vocal cord. That is the posterior cricoarytenoid muscle. So the safety muscle of larynx is the posterior cricoarytenoid and it is the only abductor of larynx. And adductors, what are the adductors then? Adductors include lateral cricoarytenoid. Where is it? Lateral cricoarytenoid is an adductor. Then interarytenoid is an adductor. Then thyroarytenoid, external part. Internal part of thyroarytenoid is called vocalis, or the medial part of thyroarytenoid is called the vocalis muscle, which is a tensor, but the lateral part of or the external part of thyroarytenoid is an adductor. So thyroarytenoid, lateral coracoarytenoid, and interarytenoid, they adduct or they come the both. So if they adduct, what happens? This closure of vocal cords will happen. Abduction means it will go laterally. Okay. So only abductor is the posterior cricoarytenoid. And I already told you this cricothyroid, which is only intrinsic muscle lying outside the larynx, and the vocalis, which is the medial part of thyroarytenoid, they are tensors. Okay. It tenses the vocal cord. So this thyroepiglottic, interarytenoid and ariepiglottic muscles are open and close the laryngeal inlet. They are the inlet act. Okay. So all these are important. So I told you that safety muscle of larynx is the posterior cricoarytenoid. So the safety nerve of larynx is the internal branch of superior laryngeal nerve. That again we will discuss along with the nerve supply. So remember, the safety muscle is the posterior cricoarytenoid, which is the only abductor, and the safety nerve of larynx is the internal branch of superior laryngeal nerve. And in this regard, you have to remember two laws: Simmons law and Wegener-Grossman law. What are they? Simmons law is that in any organic pathology of larynx, the posterior cricoarytenoid is first to be affected, and this posterior cricoarytenoid is first to be affected and last to be recovered. So if there is any organic lesions, the most lazy one, which is going to fall in bed for longer time, is the posterior cricoarytenoid muscle. It is the first to be affected and last to be recovered. While all the other adductors, they are last to be involved and first to be recovered. So this is Siemens law. S-C-M-O-N apostrophe S. Siemens law. And the Siemens law has 3 stages also that I will discuss again. And what is this Wegener-Grossman law? That is, in recurrent laryngeal nerve injuries or recurrent laryngeal nerve palsy, the vocal cord assume a median or a paramedian position because the cricothyroid muscle is there, which is acting as a adductor. So that is called Wegener-Grossman law. So these two we have to remember. Siemens law is something associated with the posterior cricoarytenoid, and Wegener-Grossman is in recurrent laryngeal nerve injuries. Coming to the nerve supply, there are mainly two nerves. One is an external laryngeal, superior laryngeal nerve, and the recurrent laryngeal nerve. Superior laryngeal nerve again divides into an internal laryngeal nerve and an external laryngeal nerve. Okay. Internal laryngeal nerve goes inside the larynx, and external laryngeal nerve is coming down, and the recurrent laryngeal nerve. So below the level of vocal cord, sensory as well as motor supply is by the recurrent laryngeal nerve below the level of vocal cords. And above the level of vocal cord, internal laryngeal nerve is only sensory, and cricothyroid is supplied by external laryngeal nerve. So regarding sensory supply, above the level of vocal cord, it is by the internal laryngeal nerve, and below the level of vocal cord, it is a recurrent laryngeal nerve. And all intrinsic muscles of larynx except cricothyroid is supplied by recurrent laryngeal nerve, and cricothyroid is supplied by the external laryngeal nerve. Okay, so remember, sensory supply of supraglottic larynx up to the level of vocal cord is from internal laryngeal nerve, while the sensory supply below the level of vocal cord is by the recurrent laryngeal nerve. So the main cranial nerve supply in the larynx, which is the main cranial nerve supply in the larynx? It is a vagus nerve, and this vagus nerve supplies via superior laryngeal nerve and recurrent laryngeal nerve. And Galen's anastomosis, you have to remember, or otherwise called ANSA of Galen or ramus anastomoticus. At least remember Galen's anastomosis. What is that? See, the internal laryngeal nerve is sensory, and also recurrent laryngeal nerve is sensory. So if there is an anastomosis between this recurrent laryngeal nerve and the internal laryngeal nerve, actually that will cover the entire sensory supply of the vocal cords, of the larynx, isn't it? So that is called Gallen's anastomosis. So if you want to completely anesthetize the larynx, you can give anesthesia to this Gallen's anastomosis, injections or surface anesthesia of Gallen's anastomosis. So it is between internal laryngeal nerve and recurrent laryngeal nerve. But if the anastomosis is between recurrent laryngeal nerve and the external laryngeal nerve, so that is called the human communicating nerve. These two you have to remember. In Gallen's anastomosis, it is purely sensory between recurrent laryngeal and internal laryngeal. But in human communicating nerve, it is between two motor, that is external laryngeal nerve and the motor branches of recurrent laryngeal nerve. And this recurrent laryngeal nerve goes anterior, posterior, or in between the branches of inferior thyroid artery, and it passes under the inferior constrictor. It is usually asked under the inferior constrictor muscle to enter the larynx behind the cricothyroid joint, whereas external laryngeal nerve passes superficial to inferior constrictor. Okay, recurrent laryngeal nerve passes deep to or under the inferior constrictor muscle, and external laryngeal nerve passes superficial to inferior constrictor. So that is regarding the nerve supply. Next, I'll tell you about vocal cord. Actually, the vocal cord is a three-layered thing. It is a mucosa that is lined by stratified squamous, non-keratinizing stratified squamous epithelium, the outer layer, cover the non-keratinizing stratified squamous epithelium. And beneath the mucosa, there is lamina propria or submucosal layer, which is 3 in number. Lamina propria has got 3 layers. One is a superficial, then intermediate and deep. Okay. And this superficial layer of lamina propria or submucosa of vocal cord is very loosely arranged. And that is called the ringy space. So superficial layer of this submucosa of the vocal cord is called the ringy space. And this ringy space is only scanty submucosa without any blood vessels also. So this actually this epithelium along with ringy space is working as a single unit, and we call it as a cover. And this intermediate and deep layers together called the vocal ligament. And the beneath that is the muscle, or that is the thyroarytenoid muscle, including the vocalis part. So cover body theory. So superficial non-keratinizing stratified squamous epithelium along with the superficial layer of lamina propria or the ringy space, we call it as a cover, and the intermediate and deep along with the muscle, we call it as a body. So cover body theory of phonation, that you have to remember, cover body theory. And this ringy space is a potential space which has only scanty submucosa without any blood vessels. Okay. So that is why this vocal cord appears pale because it is covered only by mucosa, and the submucosa is scanty with absence of blood vessel. That is why usually this vocal cord appear as a pale structures, pale ribbon-like structures. And this edema fluid can collect. I already told you that ringy space is a very loose space. It's a potential space, only scanty submucosa without any blood vessel. So edema fluid can collect in this very easily, and that will lead to ringy edema. So if there is any chronic irritation, then edema fluid may come and collect in this superficial space, so called ringy edema. Okay, so non-keratinizing stratified squamous epithelium and the lamina propria is or submucosa divided into superficial, intermediate and deep layer, and beneath that is the muscle layer, that is the thyroarytenoid muscle, right? So that is ringy space. Along with that, anatomy complete ആയിട്ടില്ല, എന്നാലും അതിനൊപ്പം ഞാൻ benign laryngeal lesions പറയാം അടുത്തത്. I know first we are in the vocal nodule. So vocal nodule is otherwise called teacher's nodule or singer's nodule or clergyman's nodule or screamer's nodule. Because you all know that vocal nodule is definitely due to voice trauma, either misuse or overuse. So otherwise called teacher's nodule or singer's nodule or clergyman's nodule, screamer's nodule. It is usually bilateral at the junction of, this is here, an early nodule is there. So it is bilateral. Usually this is not typical. Vocal nodule happens bilaterally at the junction of anterior and the middle third of vocal cords. Okay, this is anterior, middle and posterior. At the junction of anterior and the middle third, usually bilateral. Etiology, I already told you, vocal abuse. Another etiology is reflex. Then treatment is mainly speech therapy. With speech therapy, in most of the cases, nodule will disappear. Along with, I already told you that another cause is, and other than vocal abuse, it is a reflex. So what will be the treatment? Proton pump inhibitors may be added to prevent a reflux also. And if the patient is not getting better with your speech therapy or proton pump inhibitor, then surgical treatment has to be chosen. So that is microlaryngeal excision and along with the speech therapy also. So that is vocal nodule. Okay, so vocal nodule, otherwise called teacher's nodule or singer's nodule or screamer's nodule. And it is usually bilateral at the junction of anterior and the middle third of vocal cord. Causes, vocal abuse and reflux. So treatment, speech therapy and treatment of reflux by proton pump inhibitors. And what is vocal cord polyp? The difference is that vocal nodule is usually bilateral, whereas vocal cord polyp are usually unilateral. The site is same in both cases. In vocal nodule and in vocal polyp, vocal cord polyp, it happens at the junction of anterior and the middle third of vocal cord. But vocal cord polyps are unilateral, vocal cord nodules are usually bilateral. Okay. And here the etiology is usually phonotrauma, vocal abuse, chronic irritation like smoking. Treatment is again surgical, microlaryngeal excision. But vocal nodule, we can mainly, it will respond mainly to speech therapy. Vocal cord polyp usually need a microlaryngeal excision. You can use either a laser excision or cold nodules, cold instruments can be used. Then Ringis edema, I already explained. And Ringis edema, I told you that it is diffuse edema of the Ringis space leading to irreversible fusiform swelling of the vocal cord. Again, Ringis edema is usually bilateral. The commonest etiology for a Ringis edema is smoking and also extraesophageal reflux vocal strain. But mainly smoking is associated with Ringis edema, and also hypothyroidism has got to be an association with the Ringis edema. So Ringis edema is usually associated with the most common association is with smoking and hypothyroidism. Usually in Ringis edema, the bulk of vocal cord are increasing. See here, in Ringis edema, this bulk, all the superficial Ringis space will be filled with the edema fluid. So the bulk of this vocal cord will be too much. So that what will happen? There will be a low-pitched, hoarse voice. Low-pitched, hoarse voice. It will be like that. Okay, pitch will be very low and will be very hoarse also. And in severe cases, sometimes there will be stridor. Or these all the bilateral vocal cord become very, it will be very bulky. So that a low-pitched, hoarse voice and also stridor in severe cases. So what will be the treatment? So if it is all the causes, etiology should be corrected, and if it is not getting better, steroids can be given. Even then, if it is not getting better, you have to go for a superior chordotomy. Okay, that is incising the superior surface of the vocal cord to serve in the medial vibrating at this upper part we put an incision and remove the edema fluid. Okay, that is through the microlaryngeal surgery. So that is Ringis edema. Next one is sulcus vocalis, benign laryngeal lesion. For sulcus vocalis, actually the invagination of the medial vocal cord mucosa to the ringy space up to the vocal ligament, that is actually you can see a sulcus in the vocal cords. Okay, there will be a groove in the medial surface. Which is the medial surface? This is superior surface. This part is a superior upper part, and this part is a medial, two medial borders. Okay, so in the medial border there will be a groove. There will be a groove, and that can be graded into different area, different grades. That's not important for you, I think. So there will be a groove on the medial surface. It is called sulcus vocalis. Okay. So the investigation of choice for a sulcus vocalis is stroboscopy. That you have to remember. Sulcus vocalis, investigation of choice is stroboscopy. Right. And another question usually asked is, what is a pseudosulcus? In sulcus vocalis, the treatment is microlaryngeal excision or release of sulcus from the vocal ligament, or injection of collagen or fat between mucosa and the vocal ligament. See, don't get confused. This is the medial surface. So in the medial surface, invagination of this mucosa to the ringy space up to the vocal ligament. This mucosa will invaginate and it will come and attach up to the vocal ligament. So what will happen? There will be a groove on the medial surface. So what treatment you can give? You can give microlaryngeal excision, or you can release this sulcus from the vocal ligament, or you can inject collagen or fat into this space so that this invagination will go back. Okay, so that is treatment of sulcus vocalis. But in a pseudosulcus, there is edema of the undersurface of the vocal cord secondary to acid reflux into the larynx. So actually there is no sulcus, but it is a pseudosulcus. It gives the appearance of a sulcus by edema of the undersurface of vocal cord. So the cause of pseudosulcus is secondary to acid reflux. Okay, so that is asked so many times, pseudosulcus. Another benign lesion is an arytenoid granuloma. It can be of two types. One, it can be an intubation granuloma, or it can be a contact granuloma. So intubation granuloma usually occur over the vocal process of arytenoid. As the name suggests, it is secondary to long-term intubation. Treatment is again microlaryngeal excision with laser or cold instrument. And in a contact granuloma, otherwise called contact ulcer or contact pachydermia or a kiss ulcer, we call it. Contact granuloma synonyms are contact ulcer, contact pachydermia, or kiss ulcers. That happens similarly on both sides. That is why. That is due to faulty voice production leading to repeated high velocity interactive vocal process. Because of faulty voice production, what will happen is these two vocal cords will come and touch each other. They impact on each other, or they will beat on each other, so that there will be granuloma formation on the vocal process of arytenoids. Okay, so usually due to vocal abuse, other than abuse, it can be due to acid reflux. So the patient will complain of change in voice, vocal fatigue, throat clearing, discomfort, etc. The treatment is mainly speech therapy along with anti-reflux medication. But if the lesions are persisting, you have to go for a microlaryngeal excision to remove it. Okay, and also the specimen has to be sent for histopathology to exclude a malignancy. So intubation granuloma usually occurs on the vocal process of arytenoid due to repeated or long-term intubation, and contact, that is usually unilateral intubation granuloma. and content granuloma usually bilateral. Another one is JORRP. What is that? This is approved or authorized short form, that is juvenile onset recurrent respiratory papillomatosis. Juvenile onset recurrent respiratory papillomatosis. Okay. And it is caused by human papilloma virus, mainly type 6 and type 11. And type 11 is associated with a more severe disease. So, juvenile onset recurrent respiratory papillomatosis caused by human papilloma virus 6 and 11. And 11 is associated with a more severe disease. Okay. What are the treatment options of JOP? Treatment options are treatment of choice is microlaryngeal or endolaryngeal excision with the carbon dioxide laser. Okay. Recently, we can also use, it's not recently actually, long time back, micro debriders, we can also micro debride it. So, the treatment of choice as now it is, as of now, the treatment of choice is microlaryngeal or endolaryngeal excision with carbon dioxide laser or using micro debriders. Okay. And in solitary papilloma in adult is a premalignant lesion and that can lead to squamous cell carcinoma. Okay. In juvenile onset recurrent respiratory papillomatosis and in adult it is solitary papilloma, and the solitary papilloma is a premalignant lesion which can lead to squamous cell carcinoma. And also papilloma is the commonest benign tumor of the larynx. That also you have to remember. Okay. Then along with this, I'll briefly tell about symptoms and signs of tuberculous larynx. That is also repeatedly asked. In tuberculosis larynx, the early sign of a tuberculous laryngitis is adduction weakness. Sign. Early sign of tuberculous laryngitis is adduction weakness. Weakness of adduction. And the symptoms include a weak voice, hoarseness, throat pain, and odonophagia. Okay. So, the symptoms of tuberculous laryngitis are weak voice, hoarseness, pain, throat, and odonophagia. And the earliest sign of tuberculous laryngitis is adduction weakness. It is adduction weakness. Okay. And the classical sign, pathognomonic of tuberculous laryngitis is interarytenoid mammillation and granulations. And this, remember, this tuberculosis predominantly affect the posterior commissure or the posterior part of larynx. So, the classical sign is interarytenoid mammillation and granulations in the interarytenoid area, that is on the posterior part. Okay. And the earliest sign is an adduction weakness. And mouse-nibbled ulcerations on the vocal cord, ulcerations of arytenoid, turban epiglottis, and pale mucosa is also seen in tuberculous laryngitis. So, the earliest sign is adduction weakness. The classical sign is interarytenoid mammillation and granulation tissue. Okay. So, remember the word turban epiglottis, mouse-nibbled ulcerations. They are seen in tuberculous laryngitis. But in leprosy, it is knob-like epiglottis. Okay, don't get confused. Turban epiglottis in tuberculosis, knob-like epiglottis in leprosy. Okay, right. So, these are some of the benign laryngeal lesions. Next is different positions of vocal cords. This also, so many questions are asked repeatedly. So, if you can remember this chart, it will be better. In this picture, you can see if the vocal, this is a vocal cord. If it is in the midline, we call it as median position. Okay. So, usually during phonation, the vocal cords are in the median position or the midline position. But it can also happen in a recurrent laryngeal nerve palsy. So, median position and paramedian. Paramedian position is during strong whisper. നമ്മൾ കാര്യമായിട്ട് പിന്നെ എന്താ പറയുന്നത് രഹസ്യം പറയാ വിസ്പർ ചെയ്യലോ വിസ്പർ ചെയ്യുന്നു strong whisper. The cord is in the paramedian position. That is 1.5 millimeters from the midline. So median, then 1.5 millimeter is paramedian. So this median position and paramedian position can happen in recurrent laryngeal nerve palsy. So usually in normal phonation, it is in the median position. In strong whisper, it is the paramedian position. Okay. Another position is the cadaveric position. This is cadaveric or intermediate. We call cadaveric or intermediate position. That is, it is the neutral position from which abduction and adduction will take place. So it is 3.5 millimeters, 3 to 3.5 millimeters from the midline. It is the intermediate position. ഈ ഒരു പൊസിഷനിൽ നിന്നാണ് അഡക്ഷനും അബ്ഡക്ഷനും നടക്കുന്നത്, ഇന്റർമീഡിയറ്റ് പൊസിഷൻ. That happens in paralysis of both RLN and SLN. That is the recurrent laryngeal nerve and superior laryngeal nerve. Combined palsyയിലാണ് ഇന്റർമീഡിയറ്റ് ഓർ cadaveric പൊസിഷൻ വരുന്നത്. Gentle abduction അടുത്തതാണ്. That is in quiet respiration you get a gentle abduction of the vocal cord. That is 7 millimeters from the midline. Slight abduction or gentle abduction 7 millimeters from the midline. And full abduction is again 9 millimeters from the midline, 9 to 9.5 centimeters from midline terms from the midline. So that happens in deep inspiration. So this you have to remember. In RLN paralysis, the cord can be either in the median position or in the paramedian position. And combined palsy usually get the vocal cord in a cadaveric position. Why? Because if there is only a recurrent laryngeal nerve palsy, both vocal cords in recurrent laryngeal nerve palsy, this external laryngeal nerve is intact. So the cricothyroid will be acting normally. It is got a cricothyroid is an adductor. So the adductor action of the cricothyroid will allow the vocal cord to meet in the midline and the patient will be having a normal speech. But in a combined palsy, this cricothyroid is also paralyzed. So the vocal cord will go for a cadaveric position. This is called the Wegener-Grossman law, which is already explained earlier. Okay. Wegener-Grossman, Wegener-Grossman law. Combined palsy, we will get the vocal cord in the intermediate to cadaveric position because cricothyroid is also paralyzed. So there is no adductor action. If the cricothyroid is functioning because ELN is intact, then the vocal cord will assume only a midline or a paramedian position and the speech will be normal also. Okay. Right. So remember the Wegener-Grossman law. Then along with this, we will go to the neurological affections of larynx. Okay. So what is the supply of larynx? It is by the vagus nerve, by the superior laryngeal and also the recurrent laryngeal. Okay. And on the right side, recurrent laryngeal nerve arises from the vagus nerve at the level of subclavian artery. It hooks around the subclavian artery on the right side and it ascends between trachea and esophagus. This is on right side. So right side, the recurrent laryngeal nerve is from hooks around the subclavian, and on the left side, it goes into the mediastinum and then arches around the arch of aorta and then ascends to the neck to lie between the tracheoesophageal groove. Okay. So which one is longer? The left is longer. Okay. So obviously, more chance of injury to the left recurrent laryngeal nerve. Okay, because it has got a longer course, more vulnerable to injury. So, if the patient is having a left recurrent laryngeal nerve palsy, the cause can be in the superior mediastinum also, other than neck. Okay, Right injury will be, or the cause will be mostly in the neck only. If it is the left recurrent laryngeal nerve palsy, you have to look into the mediastinum also. Neck and mediastinum for left side. Okay. And another thing is that in the neck, this recurrent laryngeal nerve comes in close relation with the inferior thyroid artery as it goes into the thyroid gland. So the artery may cross anterior or posterior to the nerve, or it may lie in between the terminal branches of the artery. And because of the close proximity, the right recurrent laryngeal nerve is more liable to be injured during thyroidectomy. This is tricky. This is thyroidectomy is right recurrent laryngeal, because the cause is in the neck also. There is no it's not going for the length. On the right side, it is more closely related to the inferior thyroid artery. So during thyroidectomy, there is more chance of injury to the right recurrent laryngeal nerve, and otherwise, because the left is long, there is more chance of injury to the left recurrent laryngeal nerve. Okay. Superior laryngeal nerve, this is regarding the recurrent laryngeal nerve, and the superior laryngeal nerve, on the other hand, it arises from the which ganglion? Inferior ganglion of the vagus nerve, or just below the skull base. So superior laryngeal nerve arises from the inferior ganglion of the vagus nerve, just below the skull base, and it descends on the side wall of pharynx. First, it is posterior to the side wall, then it is medial to the internal carotid artery, then it divides into an external at the level of greater cornea of hyoid bone. This is hyoid bone, lesser cornea, and greater cornea. So at the level of greater cornea or greater cornea of hyoid bone, it divides into an internal laryngeal nerve and an external laryngeal nerve. Okay. So superior laryngeal nerve arises from the inferior ganglion of the vagus nerve, just below the skull base, descends on the side wall of pharynx, medial to the internal carotid artery, and at the level of greater cornea of hyoid bone, it divides into an internal laryngeal and an external laryngeal. And the internal laryngeal nerve pierces which membrane? Thyrohyoid membrane. This one is hyoid thyroid. So thyrohyoid membrane. So this internal laryngeal nerve pierces the thyrohyoid membrane along with the superior laryngeal artery, and it supplies sensory innervation to the larynx above the level of vocal cord. We already discussed that. Okay. And what about the external laryngeal nerve? External laryngeal nerve, it descends, goes down deep to the superior thyroid, superficial to the inferior constrictor muscle, and then it supplies the cricothyroid muscle. Okay. So I already told you, this recurrent laryngeal nerve goes behind the inferior constrictor or under the inferior constrictor, and this external branch of superior laryngeal nerve, it goes above or over the inferior constrictor muscle. Okay, so this thing you have to remember. So in combined paralysis, what should be the lesion? Combined paralysis should be in the lesions should be very high. So either in the lesions of nucleus ambiguous, or it is in the vagus nerve proximal to the origin of the superior laryngeal nerve. Should be above the inferior ganglion of vagus. So it should be proximal, high lesions. So in high lesions, either in the nucleus ambiguous or in the vagus nerve proximal to the origin of superior laryngeal nerve, there will be combined paralysis of both nerves. So the lesion should be in the brainstem posterior fossa, or in the skull base, or in the jugular foramen, or should be in the parapharyngeal space. In the neck, also combined palsy can happen, especially after thyroidectomy, after total thyroidectomy, when there is surgical injury to both external and recurrent laryngeal nerves. Okay. At this level, if there is injury happens to both external and recurrent laryngeal nerve, again there will be a combined palsy. So nucleus ambiguous, vagus nerve lesions, or after thyroidectomy, you can get a combined palsy. So this, remember this picture. Okay. So this is the nerve supply along with the vocal cord palsies. And there are some syndromes associated with the vocal cord paralysis. One is an Avelli syndrome. That is high lesions Usually in the lesions of the nucleus ambiguous, what will happen? 9 and 10 will be affected. So if 9 and 10 is affected, there will be involvement of paralysis of palate, pharynx and larynx. Okay. And if the superior part of nucleus is involved, or if only the superior part of nucleus ambiguous is involved, the larynx will be spared. In complete affection of the nucleus ambiguous, this 9 and 10 will be affected. So palate, pharynx and larynx will be affected. But if only the superior part of nucleus is involved, larynx will be spared. And in Avelli syndrome, there will be spinothalamic tract is also affected. So there will be palatopharyngeal paralysis with loss of contralateral pain and temperature sensation. So that is called Avelli syndrome. Okay. So palatopharyngeal paralysis along with the loss of contralateral pain and temperature is Avelli syndrome. Okay. Palatopharyngeus with the loss of contralateral pain and temperature because spinothalamic tract is affected, right? Another one you have to remember, all these you have to make it by heart. Okay, then these are 4 MCQs. By heart പഠിക്കേ പറ്റുള്ളൂ കേട്ടോ. Jugular foramen syndrome ആണ്. Jugular foramen കൂടെ ഏതൊക്കെ nerves ആണ് പോകുന്നത്? Glossopharyngeal, vagus and accessory. അല്ലേ? 9, 10 and 11 cranial nerves are passing through jugular foramen. And how the 12 comes here? Glossopharyngeal എങ്ങനെയാ വരുന്നത്? I mean hypoglossal എങ്ങനെയാ വരുന്നത്? They are joined by the 12th nerve affected as it passes out through the hypoglossal canal. And also, Horner syndrome will happen because cervical sympathetic chain at the level of cervical sympathetic chain which ascends to the skull base. Okay. So, Werner syndrome happens when there is 9, 10 and 11. Then this one, SCH, MIDT in 10 and 11 is affected. Collet-Sicard 9, 10, 11 and 12. And along with the a sympathetic chain, if affected, then it becomes a bilirate. So all these make it a by heart. Okay. Remember this picture and Kanapadam Padishu. So what will be the cause of all these? Lesions will be in the skull base fractures or in glomus tumors or malignancy of nasopharynx or basal meningitis or cholesteatoma. Then parapharyngeal tumors, jugular bulb thrombosis. In all these cases, this jugular foramen syndrome can happen. Okay. So, ideally, through the jugular foramen, only 9, 10 and 11 is going. And close proximity to the hypoglossal canal and cervical sympathetic chain. Call it Sicard and bilirate. Okay. Then I'll tell about vocal cord palsy. As we have covered the supply, I'll tell a word more about unilateral as well as bilateral vocal cord palsies. Okay. Unilateral vocal cord palsy എന്ന് കുറെ അധികം MCQs ചോദിച്ചിട്ടുണ്ട് കേട്ടോ. ഇതെല്ലാം ഓരോ MCQ ആണ്. So in unilateral vocal cord palsy, commonest cause of a unilateral vocal cord palsy is idiopathic. Post viral കൂടെ കിടക്കുന്നുണ്ട്. Usually it is idiopathic. Idiopathic അറിയാലോ എന്താണ്? Cause is unknown. But Cori post viral ആണ് കൊടുക്കുന്നത്. Other causes are trauma, tumor, surgery, infections, etc. And on the left side, there are some named syndromes on the left side. Left vicrolaryngeal nerve palsy. One is Pankos tumor of lung at the thoracic inlet. Okay. So that will lead to left vicrolaryngeal nerve palsy. So, Pankos tumor of the lung can involve the left vicrolaryngeal nerve palsy at the thoracic inlet. Okay. And if this, it is going infiltrating posteriorly, can also produce a phrenic nerve palsy. So, Pankos tumor of the lung at the thoracic inlet will lead to left vicrolaryngeal nerve palsy. And if this tumor is infiltrating posteriorly, then it can lead to a phrenic nerve palsy also. So what will happen there? If there is phrenic nerve palsy, there will be involvement of the diaphragm. Okay. So if there is vocal cord palsy along with the diaphragmatic palsy, or otherwise they can ask you as diaphragmatic palsy along with hoarseness of voice. It is called a Kinkert syndrome. Because there is vocal cord palsy, the patient can present as hoarseness. So these two, that is a Pancoast tumor of the lung at the thoracic inlet. It is infiltrating posteriorly or going posteriorly, causing a phrenic nerve injury. This can present as hoarseness along with the diaphragmatic palsy, and that is called a Kinkert syndrome. Okay. And if the enlarged left atrium in mitral stenosis compressing on the left recurrent laryngeal nerve palsy, then what will be the presentation? There will be mitral stenosis along with the hoarseness. So that is called Ortner syndrome. The enlarged left, in mitral stenosis, there is enlarged left atrium that is causing, going and causing compressing on the left recurrent laryngeal nerve, causing a recurrent laryngeal nerve palsy, left vocal cord palsy. So it will present as hoarseness. So MS along with hoarseness is Ortner syndrome. Okay. So these two syndromes are happening on the left recurrent laryngeal nerve palsy. Right? So what will be the symptom of the patient? Usually it is breathy voice and mild aspiration. Aspiration in a unilateral vocal cord palsy or recurrent laryngeal nerve palsy, aspiration is not at all a symptom. If at all is happening, it's only mild. Usually aspirations happen in bilateral or superior laryngeal nerve involvement. Only aspiration happen. In a unilateral vocal cord, usually it is breathy voice. Patient present with a dysphonia, shortness of breath and swallowing difficulty. Okay. So CT scan from skull base to sternal angle is the investigation of choice. And I already told you on the right side, usually the lesion is in the neck, skull base to neck, and on the left side it can go to the mediastinum. So skull base to superior mediastinum. Any lesion from skull base to superior mediastinum can cause palsy on the left side. Okay. So what are the other mediastinal causes like aneurysm of the arch of aorta or apical tuberculosis or cardiac surgeries like a PDA ligation, other intrathoracic surgeries can cause a left vocal cord palsy along with these two syndromes also. Okay. So how will you manage a case of unilateral vocal cord palsy? How will you manage it? This is again usually asked. You can wait for a spontaneous recovery. How long you can wait? You can wait for a maximum of 6 months because spontaneous recovery from a paralysis or compensation can happen for up to 6 months. So you can wait for 6 months. What is this compensation? It is a process by which the opposite on the other side, see here, this is a unilateral vocal cord palsy. So in some cases, this opposite normal cord will overreact and it will try to come into the midline. Overacting normal cord will compensate. So glottic competence will maintain. So that can happen up to 6 months. So in a unilateral vocal cord palsy, you can wait for up to 6 months. If there is no recovery, then you have to go for surgical procedures. And the surgery of choice is type 1 thyroplasty, that is medialization. This is from the lateral position, this vocal cord has to be medialized. So type 1 Ishiki thyroplasty is the surgery of choice or medialization thyroplasty. Remember this. If there is no time to discuss what is this type 1 Ishiki thyroplasty, just remember that Ishiki type 1 thyroplasty is the surgery of choice for a unilateral vocal cord palsy. And so that what will happen, this paralyzed vocal cord will come to the center. Also, you can give injections to this paralyzed vocal cord so that the volume will be enhanced. So injection laryngoplasty or injection to the affected vocal cord. You can use Teflon, you can use autologous fat or collagen. Okay. So, Teflon, there is high chance of an formation of granulomas. So, fat or collagen or hyaluronic acid, all these can be used for injecting into the vocal cord. So, type 1 ischithyroplasty is the surgery of choice. Okay. So, that is regarding unilateral vocal cord palsy. And in bilateral vocal cord palsy, commonest cause is, unfortunately, it is a thyroid surgery. Commonest cause of it, bilateral vocal cord palsy is thyroid surgery. And other causes like road traffic accidents or idiopathic or viral infections or cutthroat injuries or malignancies of the thyroid, malignancies of the esophagus. All these are causes of bilateral vocal cord palsy. And in neonate, and this is usually asked MCQ, neonate presenting with a bilateral palsy. It is usually, you have to rule out an Arnold-Chiari malformation. Okay. And in a bilateral vocal cord palsy, you will get in hypernasality, usually you get dyspnea, stridor, and dyspnea will be, and stridor will be there in a bilateral vocal cord palsy. Okay. So, what will be the treatment for that? So, commonest cause of a bilateral vocal cord palsy is thyroid surgery. And also remember the Arnold-Chiari malformations. So, the treatment of choice is Kashima's operation. For unilateral vocal cord palsy, what was the surgery of choice? It was type 1 medialization thyroplasty. But in here, it is Kashima's operation is the treatment of choice. Okay, Kashima operation. It's a very simple surgery by which we separate this part. This both membranous and cartilaginous part of vocal cord are divided just anterior to the vocal process of arytenoid, either using a laser or a co-ablator. Okay, so treatment of choice for a bilateral vocal cord palsy is Kashima's operation. And you can also use arytenoidectomy, otherwise called the Woodman's operation, or again cordectomy, endoscopic lateralization procedures are there. Okay, so remember, treatment of choice is Kashima's operation. If the patient is willing, the most effective treatment of bilateral vocal cord palsy is tracheostomy and speaking valve. So this vocal cord, see here, it is in the adducted position. There is no glottic space for this. So, Kashima's operation failure rate is very high. Even though it is a treatment of choice, the failure rate is very high. So, the most effective treatment, if the patient is willing, is tracheostomy along with the putting a speaking valve. Okay. So, others already I told you, Woodman operation, you have to remember cordectomy, endoscopic lateralization, effective treatment and treatment of choice. Okay. Then a word about spaces of larynx. Most important time. Spaces of larynx is actually important. One is a pre-epiglottic space, otherwise called pre-epiglottic space of Boyer. Here, see this part, pre-epiglottic space. This is infrahyoid epiglottis behind, then thyroid membrane in front, and above by hyoid bone. Okay, these are the boundaries. Pre-epiglottis space, actually it lies in front of epiglottis beneath the hyoid, infrahyoid epiglottis. It lies in front of the infrahyoid epiglottis. So the importance is that the supraglottic malignancies can spread to. Supraglottic malignancy can spread to this pre-epiglottis space. Very early spread of malignancy into this space. Hence, during laryngectomy for malignancy, this space has to be included in the dissected specimen. Okay. For malignancy larynx in a surgery chamber, hyoid bone in the kude, e pre-epiglottis space in kude. Okay. So that is the importance of pre-epiglottic space or Boyer space. And another question asked is vallecula. Vallecula is actually superior. Tongue in the രണ്ട് സൈഡിലുമാണ് vallecula വരുന്നത്. So vallecula is superior to the pre-epiglottic space. And another thing is that MRI larynx is a prognostic marker. ഈ ഒരു soft tissue ആയതുകൊണ്ട് soft tissue images are better seen in MRI. So MRI larynx, if you suspect any spreading to this pre-epiglottic space, go for an MRI larynx. Okay. So that is pre-epiglottic space. Another space is paraglottic space of Tucker. Okay, second one, paraglottic space. And usually this paraglottic space is on the lateral aspect. On the lateral side, there are two paraglottic spaces. Here comes a paraglottic space. So medially, there is a lateral, this is a larynx. Lateral wall of larynx is a medial boundary. And the lateral boundary is the posterior part of thyroid cartilage. Laterally, thyroid cartilage, and supromedially, you can get the pre-epiglottic space. Infromedially, vocal fold or the conus elasticus. And this actually, this space surrounds the laryngeal inlet. Okay. So, and here is a paraglottic space. And if in transglottic, this space is involved by transglottic. Transglottic means if it is going from true vocal cord, this is true vocal cord and this is a false vocal cord. In between is a ventricle. So if this ventricle is involved or the paraglottic space is involved, it becomes a transglottic malignancy. So transglottic malignancy, the stage of malignancy will be changed and also treatment will be changed. Okay. So that is importance of paraglottic space. Again, in spread of malignancy and the transglottic spread. Another one is a water can of larynx. What is this water can of larynx? Water can. What is that? It is saccule. See, saccule. Actually, it is a diverticulum of mucous membrane. And this start from the anterior part. I already told you there is a laryngeal ventricle. Between this vocal fold and the vestibular fold, there is a space called laryngeal ventricle. So the anterior part of this laryngeal ventricle will extend between this false cord and the thyroid cartilage. This blue is a thyroid cartilage. So this anterior part of this ventricle will extend between this false cord and the thyroid cartilage, and that is called the saccule. And the saccule has plenty of mucous glands. And what is the main purpose of this mucous glands? Mucous glands will lubricate the vocal cords. So that is why it is called the water can of larynx. Okay. So the water can of larynx is the saccule because it has got plenty of mucous glands, and the main purpose of this mucous glands is to lubricate the vocal cords. Okay. So that is why it is called water can of larynx. And when distended, it can protrude through the thyroid membrane into the neck. So then it will become a laryngocele. There is also an internal laryngocele and there is also external laryngoceles. So distension of the saccule is causing the laryngocele. So abnormally large saccule of larynx protrude externally through the thyroid membrane. This is an external laryngocele. And if it is present as a distension of the false cord and the ariepiglottic fold, it happens here. It is internal laryngocele. If it is going out through this thyroid membrane, then it becomes an external laryngocele. Okay. And this external laryngocele can present as an intermittent neck swelling, which can be inflated by Valsalva. If you ask the patient to do a Valsalva, if it is projecting outside, then it becomes an external laryngocele. And what will be the presentation of the patient? Usually hoarseness and airway obstruction. If it is external laryngocele only, then it will present as a neck swelling inflated by Valsalva maneuver. Okay. So treatment is again excision. Also, you can approach it using either with cold instruments or using carbon dioxide laser. You can do it. And investigation of choice is preferably MRI by doing with and without Valsalva maneuver. That is the investigation. Because it is soft tissue, it is better seen with an MRI rather than CT scan. So, water can of larynx is acute, and when distended, it can present as an internal laryngocele, or if it is going through the thyroid membrane, then it become an external laryngocele. Okay. Then in nutshell, usually the pathology in supraglottis will present as dyspnea during inspiration and dysphagia. Supraglottis has something more to do with the swallowing because of the presence of epiglottis. So pathology usually present with an inspiratory dyspnea and dysphagia. But if it is in the glottis, I already told you the glottis is formed by the true vocal cords, anterior commissure and the posterior commissure. So there will be a biphasic dyspnea and hoarseness. But if it is in the subglottis, that is below the level of glottis, the hoarseness will not happen. The true vocal cords are associated with your voice, so hoarseness will be there. But in subglottis, usually it is biphasic dyspnea. So inspiratory dyspnea with supraglottis, biphasic dyspnea can happen in both glottis and subglottis. But if it is associated with hoarseness, it is more in favor of glottic pathology. And if there is a lower respiratory tract problem, that will lead to an expiratory dyspnea. Okay, so this you have to remember. Lower respiratory tract usually associated with the expiratory problems, expiratory dyspneas. Okay. Then IL is indirect laryngoscopy is asked sometimes. In indirect laryngoscopy is a type of laryngeal examination. So you have all should must have been familiar with the indirect laryngoscopy by using an indirect laryngoscopy mirror. So we will ask the patient to open the mouth, and using a pre-warmed in IL mirror, we do an indirect laryngoscopy. So what are the structures you see? This is the structures you see in an indirect laryngoscopy. First you see the base of tongue, then medial and lateral glossoepiglottic folds. And between this median and the lateral glossoepiglottic fold, there is vallecula. Then you will see epiglottis. Which part of epiglottis? That is the lingual surface of epiglottis. See, this is base of tongue. So this part of epiglottis, that is the lingual surface. The part which is facing the tongue is the lingual surface. Laryngeal surface, it is a blind area. You cannot see the laryngeal surface of epiglottis in an indirect laryngoscopy. So you can see the lingual surface of epiglottis. Okay. Then what will you see? On tilting, you can see the false chord and the true chord. And on both sides, you can see the aryepiglottic fold, arytenoids, and the piriform fossa. Entire part of piriform fossa is not seen, only the upper part. Apex of piriform fossa is again a blind area. And the interarytenoid area and the post-cricoid areas are again not seen with an indirect laryngoscopy. So you can see the base of tongue, you can see the median and lateral glossoepiglottic fold and the lingual surface of epiglottis. Then on tilting, you see aryepiglottic fold, arytenoid, upper part of piriform fossa, false chord and the true chord. And sometimes you can see the tracheal rings also in between the vocal cords. So these are the structures. So the question will be, what are the blind areas seen in blind areas of larynx on indirect laryngoscopy? So what will be the blind area? One is laryngeal surface of epiglottis. And second is laryngeal ventricle. Ventricle is an area between this false chord and the true chord. So that part you cannot see. Anterior commissure you will not be seeing in an indirect laryngoscopy. That is another blind area. Subglottis, that is the under surface of vocal cord, again not seen. And also apex of piriform fossa. So the laryngeal surface of epiglottis 1, laryngeal ventricle 2, then anterior commissure 3, subglottis or the under surface of vocal cord 4, and apex of piriform fossa 5. There are 5 blind areas by doing an indirect laryngoscopy. Okay. Then optical illusions of indirect laryngoscopy is again commonly asked. Optical illusions. What are the optical illusions? One is side inversion. Right vocal cord will be seen as a left vocal cord and left side as right. This is direct laryngoscopy picture, and this is indirect laryngoscopy picture. So there will be side inversion, that is one. Another one is anteroposterior reversal. See, here this is the anterior part, but normally in a direct laryngoscopy, the anterior part is here. So anterior posterior reversal will be there. Anteroposterior shortening will be there. In indirect laryngoscopy, this anteroposterior shortening will be seen. But in normally, this anteroposterior length will be more. Then depth perception will be reduced. See here and compare with this. Depth perception will be reduced. Then brightness will be more in this. See, if you are using more of bright light, the brightness will be more than normal. And this vocal cord appears to have an outer border. See here, the false cord actually will present as an outer border. And normally, there is no outer border for the vocal cords. So these are the optical illusions of vocal cord. What are they? One is a side inversion. Another one is anteroposterior reversal and anteroposterior shortening. Then reduced depth perception, increased brightness, and vocal cord appears to have an outer border. These are the optical illusions of indirect laryngoscopy. Okay. And I am sure you know the difference between direct laryngoscopy and indirect laryngoscopy. Alle? Parayandallo. That is also again, so many times this difference between indirect laryngoscopy and direct laryngoscopy is asked. Okay. These are the six are the optical illusions of indirect laryngoscopy. And what is the position of direct laryngoscopy? That's a favorite MCQ. Direct laryngoscopy position. This normal. This is the position. That is supine, patient supine with the neck flexed on chest and head extended on the neck. Okay. Neck is flexed on the chest and head is extended on the neck. Head extension pillow or head ring and neck is flexed on the chest. So that what will happen? This laryngeal axis and the pharyngeal axis will be in the same or parallel. Usually ഇങ്ങനെയാണ് വരുന്നത്, കട്ട് ചെയ്ത് വരും. പക്ഷേ ഇങ്ങനെ ചെയ്യുമ്പോൾ ഈ ബോയ്സ് പൊസിഷൻ or sniffing position or barking position. These are the positions of direct laryngoscopy. All these are synonyms, same position. Flexion of neck on chest and extension of head on neck. Okay. So that this pharyngeal axis and laryngeal axis will be almost parallel. They will be in a straight line. Okay. So that is position for a direct laryngoscope. Then contraindications, absolute contraindications are cervical spine injury, aneurysm of arch of aorta, and recent cardiac illness. If there is such contraindications, we can go for a transnasal flexible laryngoscopy. If rigid endoscopy is contraindicated, TFL can be do. That is the investigation of choice in voice disorders. So a transnasal flexible laryngoscopy along with a stroboscopy. This stroboscope can be attached to both rigid endoscope and flexible endoscope. But the transnasal flexible laryngoscopy is the investigation of choice. So transnasal flexible laryngoscopy attached to and stroboscopy is the investigation of choice in voice disorders. Okay. TFL along with the stroboscopy. And this stroboscopy is I already told you for glottic area along with the transnasal flexible laryngoscope. The investigation of choice is video stroboscopy. Here we examine the larynx under intermittent lighting to study the vibratory pattern. So flashes of light ആണ് യൂസ് ചെയ്യുന്നത്. അവിടെ mucosal waves at the edge കാണാൻ പറ്റും, and that will be different for each organic pathology. Okay, so just remember video stroboscopy and transnasal flexible laryngoscopy. And another one is an contact endoscopy. It's actually by doing a contact endoscopy, we can differentiate benign lesions from malignant lesions of larynx. We use dyes like methylene blue, toluene blue, or Lugol's iodine, and we stain the epithelium with these dyes, and we apply a modified laryngeal endoscope against the mucosa at a magnification of into 60 into 60 into 150. 60 into 150 dimensions. Okay, that is a magnification for a contact endoscopy. 60 and into 150. So this, if there is change in color, it is malignant. If there is no change in color, it's a benign. So that is contact endoscopy. And by doing this, pre-malignant conditions like dysplasia can be detected very early. That is the advantage of contact endoscopy. Okay. So dyes used are, you have to remember the dyes used. One is methylene blue, then toluene blue, and also Lugol's iodine. Okay, I think the time is reaching 9 o'clock. So remember all these. Another okay. So contact endoscopy, video stroboscopy, and also anatomy of larynx, and the difference between adult and infant larynx. Then benign lesions of vocal cords, Ringis edema, then indirect laryngoscopy and direct laryngoscopy. And also the nerve supplying the larynx, recurrent laryngeal nerve. Then the different intrinsic muscles, actions of each one, vocal cord palsy, both benign and malignant. Okay. So I think we have only this much of class, only two. We had one in the earlier and this one. So 2 classes for ENT. And the exams are, even if it is not postponed, study well and use your time, and all the best.